Welcome to our very last session of the day. We're so happy you could come together again this year. I'm blown away. I think every year I pretty much say there can't be any more people that would possibly come to a CRISP Summit. And every year turnout is just remarkable. Um, and I like to think back on what that means both today with the amount of collaboration and excitement and camaraderie that we can generate, but also what it meant about the past and where we came from. So I actually thought it would be fun to go back in time a little bit. Um, this is a slide from 10 years ago, and it shows how we described CRISP in 2015, 2016. You'll see some things are the same. We, of course, have this concept of a regional health information system. Of course, we're serving Maryland, the Chesapeake region. But at the time, we had CRISP DC, which was a subsidiary. Of course, now it's entirely independent, but still has data flowing seamlessly. We had some data sharing with Northern Virginia and Pennsylvania. That data sharing is still in place, although Virginia is much more robust, and I think Pennsylvania, through some national network partnerships and other coordination, is even better as well. And then we wanted to deliver data to the right place at the right time. That remains core to who we are. Some things changed. So the data source on the side, first the services we described. When we talked about long-term and post-acute care facility as a data source, we were really talking about getting rosters so we knew maybe like short stay Medicare patients who would come in and out. And that's obviously still essential. But now we have a robust nursing home connectivity program that is sharing immense amounts of data and reports with most facilities across the state. We also still have those live clinical data feeds, but they're flowing into different tools and services and our own version of an encounter service called Send. Of course, hopefully all of you realize that the image exchange program, which was relatively new 10 years ago, it now has diagnostic quality images flowing directly in and out of PACS systems into our portal viewer. And the patient searches have gone up considerably. I think we're at 3 times that at this point. I do appreciate that something that will never change is the vision. We will only do things with cooperation and collaboration. And I think, quite frankly, that is the reason we've been around and thriving for so long. Certainly what's not the reason is the old clinical portal. This is what it looked like. I don't dislike it. It's clean. There's a lot of white space, probably because there wasn't a whole lot of data. Now we're parsing clinical documents and deduplicating, and we have the full non-CDS medication set. So it would look very different if it actually had everything it could. But it did the job. It did what it needed to do. We were just about to embark on the in-context work with the Smart on Fire application. And so this was probably the last year that this portal was even available, because we had to switch over to something entirely different. But at the time, quite frankly, simply getting systems connected and data moving was a major accomplishment, and something we certainly did not take for granted. Now, and you may have seen this slide before, we talk about real-time connectivity, full participation, scale, and longitudinal data. Right? We're not just helping care coordinators with push messages. We're helping public health agencies get that similar data or the same data so they can do thorough and robust and real-time case reports. We're looking not just at the fact that a lab has come in, but we're deduplicating, we're driving it into workflows, we're helping to make sure that clinical decisions are happening as effectively as possible, and that this drives to more efficient, better outcomes. We have different ways of monitoring consent, both the traditional opt-out of the HIE, but also looking at opt-in for sensitive data sharing and based on federal actions and state laws, making sure that the most sensitive data, as determined by kind of different actors within the state of Maryland, does not leave the state. Because even though care does happen across state boundaries, certain data shouldn't flow unless the patient opts in and is very deliberate about that. On the utilization side, I said we have a lot more data flowing. We are, I think, close to 500,000 searches per week, which is just insane amounts of volume. I'm really proud of the operational consistency and the uptime that we provide. But we also are parsing in real time. We're sending data back and forth in real time. Kind of most users, kind of participants, covered entity practices, health systems, will receive data 2 or 3 different ways, because sometimes a clinician just wants the Smart on Fire app to pop up and they want to read the information. Other times, they might want the continuity of care documents to flow directly into the EHR database and then get parsed and presented for other purposes down the line. We're even doing kind of large database data transfers so that analytic and population health groups can look at large amounts of data, not these individual patient records in real time. Honestly, the way I'm thinking about this is that the value is no longer the pipes themselves. The value is really what you all collectively are building on top of them. That said, some things, again, look pretty familiar. This user story is from 10 years ago. And, of course, the programs support patients across a variety of organizations. We want the EDs to understand what community-based services are available. We want to know that the primary care and community-based providers to know that the patient's been in the hospital, and we want to measure effectiveness. This is probably a little bit too familiar for us because we still have patient panels, we still understand relationships, we still link with actionable data. And I think what I would argue is that what has changed is the depth, the timeliness, and the operational sophistication of the infrastructure that's supporting these workflows. When we were trying to enable this user story back then, we were parsing different things and kind of putting things together and not using a small amount of duct tape to make sure it worked. And now, with a variety of upgrades, with our kind of cloud native services, this data is being handled in a way that plans for all of these different purposes from all these different actors. It's really a huge difference. And so, if we think about this mature infrastructure, and as we think about where we've made investments since 2016, we still want to make sure that patients are actively receiving the best care possible. So the better clinical signal with the full dispense medication list, the better timeline view, longitudinal reports, because we're receiving those documents, parsing them, putting them in the cloud, and then able to show them over time. Hopefully is giving both point of care interactions more information so you all can do your jobs even better, but also so that as we plan for different programs, as we consider where we want to make community investments, we have a good sense of what's actually happening with patients. Similarly, we're trying to welcome, I believe, different types of actors into the traditional healthcare system. Certainly behavioral health, substance use disorder, rural providers can and should be on the same infrastructure, same platforms, same tools as large health systems and urban centers. So we're trying to drive better connectivity, more referrals, support for social services. I'm actually feeling very optimistic, even as we look at some of the headwinds that are happening in terms of federal funding and federal programs, as we force ourselves to think about how different agencies can work together and how we can reuse this infrastructure that CRISP provides. I think we're going to find that there actually are some incremental steps we can take that will continue on a really, really positive path. This shared infrastructure is an incredible asset for all of us. I'm very humbled and proud to be working on it. And as I think about CRISP not just being an interoperability network, think about us becoming an operational infrastructure for healthcare and public health across the entire state. It's a very powerful journey. It's been incredible to be part of it. So I just want to thank all of you for joining us here today, for joining us on this decades-long journey. We have a long way to go, certainly, but it's been, I think it's been hopefully somewhat radicalizing for the healthcare industry, because data is available as you need it, only as appropriately, so you all can do the really great work and the really challenging work of continually making a better healthcare system and a better state for all of us. So thank you, and I hope you had a great summit today.